Hi, everyone. We'll get started in a couple minutes just to see if anyone else comes in. Thank you. Okay, so we can go ahead and get started. So good afternoon, everyone. My name is Katie, and I'm one of the pharmacy residents here at Stony Brook. Thank you for attending my patient safety CE, which is for the kids, potentially inappropriate drugs in pediatrics. So firstly, I would just like to recognize that I have no financial interests or affiliations with any organizations that could be perceived as a real or apparent conflict of interest in the context of this presentation. Brand names of all products that are used in this presentation may be included for identification purposes only. In terms of our pharmacist objectives for today, we will identify medications included on the kids list, recognize common risks associated with the kids list medications, describe the rationale behind why certain medications are included on the kids list, and finally, select appropriate alternative therapies for medications on the kids list. In terms of our technician objectives, we will name the World Health Organization's definition of adverse drug reaction. We will classify pediatric populations by age. We will state the kids list definition of potentially inappropriate medications. And finally, we will identify medications and excipients included on the kids list. So firstly, we will cover some of the background information that we need to know prior to looking at the kids list itself. So before diving right into the kids list, it's important to provide some context to its use, and we'll begin by speaking about adverse drug reactions, or ADRs. According to the World Health Organization, ADRs are defined as any noxious and unintended response to a drug that occurs at doses normally used for prophylaxis, treatment of disease, or modification of physiologic function. ADRs may be preventable to some capacity regardless of their etiology. Preventing these ADRs may assist in alleviating patient and parent burden, as well as in decreasing additional costs to the healthcare system. So in order to highlight exactly how grave the issue is of ADRs is in the pediatric population, I've included some literature findings on this slide. Firstly, in a review of 21 prospective studies, including hospitalized pediatric patients, ADRs actually occurred in up to 16.8% of patients. Additionally, in a separate prospective observational cohort study, 17.7% of all children who spend more than 48 hours in a hospital experience at least one ADR. So based on these findings, as well as other available literature, it is apparent that the incidence and prevalence of ADRs are higher in the pediatric population compared to the adult population. Because of the high incidence and prevalence of ADRs in the pediatric population, it's imperative to have a tool such as the kids list that assists in mitigating some of the risk of these ADRs. One of the underlying reasons for higher rates of ADRs in the pediatric population includes off-label use. So currently, the approval and subsequent release of new medications onto the market often occurs without experience in pediatric patients, and overall there is a lack of FDA labeling and information for many medications in the pediatric population. Due to this paucity of dosing information in pediatrics, many practitioners often rely on case reports and anecdotal experience instead of evidence-based studies. Ultimately, the Best Pharmaceuticals for Children Act and the Pediatric Research Equity Act in the United States were enacted to encourage more studies of medications in the pediatric population. However, the off-label use of medications in children is still widespread, as about 50% of the medications in the United States are still not labeled for use in children. So another important contributing factor to increased rates of ADRs in the pediatric population is altered pharmacokinetics. In terms of absorption, developmental changes in intragastric pH, gastric emptying times, intestinal motilities, and absorptive surfaces affect absorption. Additionally, for example, percutaneous absorption in the neonatal population may be altered, as some neonates have a thinner stratum corneum. In terms of distribution over time as the body ages, its composition changes as total body water decreases and body fat increases. Regarding metabolism, the phase 1 and 2 hepatic metabolizing enzymes found in adults mature over time. Finally, regarding excretion, ultimately the kidney is responsible for the clearance of many drugs from the body, and the development of renal function approaches that of an adult by the first year of life. Because of the drastic differences in the pharmacokinetics of a pediatric patient versus an adult patient, the incidence of ADRs in the pediatric population is higher. So ultimately, the Pediatric Pharmacy Association commissioned a group of pediatric pharmacists to conduct a literature review regarding the use of certain medications in the pediatric population. This task force's end goal was to compile a list of medications that should be avoided or used with caution in all or a subset of the pediatric population. So the end goal of the key potentially inappropriate drugs in pediatrics or kids list is to ultimately enhance medication safety in the pediatric population by using an evidence-based approach with data from medical literature. So to summarize our introduction to the kids list, it is primarily a reference tool that is used in order to improve medication safety. The kids list contributes to the prevention of serious ADRs in children by identifying medications with high risk of ADRs. I also want to highlight that these ADRs are associated with the kids list. So these medications that are included are ones that occur at normal doses, like I said before, instead of, maybe we expect it to occur with overdoses, but no, these are ADRs actually occur at normal doses that are used in clinical practice. Ultimately, the kids list identifies medications associated with a high risk of ADRs in order to enhance quality of care, decrease costs, and identify areas that may benefit from more research in the pediatric population. So now that we have a better understanding of the context of the creation of the kids list, we can focus more on how to interpret the list itself. So in order to interpret the kids list recommendations, we must familiarize ourselves with each age stratification that's included in the kids list. Firstly, when the list is referring to newborns with very low birth weight, this is indicative of a birth weight less than 1,500 grams. Additionally, neonates indicate those who are aged less than 1 month. Infants are characterized by an age of less than 24 months, and generally speaking, children are referred to as less than 18 years of age. So now that we've covered the basics of age stratification, we can focus on the kids list medications themselves. So medications that are included on the kids list are deemed as potentially inappropriate, but what exactly does that mean? The creators of the kids list define potentially inappropriate as medications or medication classes that should generally be avoided in persons younger than 18 years because they pose an unnecessarily high risk for children and a safer alternative is available. It is important to note, however, that the specific needs of a patient may surpass the recommendations of this list. And because of this, it's important that an interprofessional team considers the preferences of the child and legal guardians when selecting appropriate medications for pediatric patients. So now that we understand the definition of potentially inappropriate, we can further categorize the kids list recommendations into either avoid or caution. Avoid describes scenarios in which the strength of the recommendation was strong or that the potential adverse effect was of life-threatening or life-altering nature. On the other hand, caution refers to scenarios in which the quality of the evidence was low or very low, the strength of the recommendation was weak, or there's still a clear therapeutic need for the drug despite evidence demonstrating higher risk in children than adults. In addition to the kids list recommendations themselves, they are accompanied by their respective strength of recommendations. In the setting of a strong recommendation, most clinicians would choose to either avoid the kids list medication entirely or use it cautiously rather than assuming the risk of an ADR. However, in contrast, a weak recommendation indicates that clinicians may vary on their decisions regarding the kids list medication. So, for example, one clinician may decide to avoid the medication completely, whereas a different clinician may choose to risk the incidence of an ADR. Finally, also accompanying each recommendation is the quality of the evidence. In the kids list, high quality indicates that further research is unlikely to alter the recommendation. Moderate quality suggests that further research may impact their recommendation. Low quality evidence indicates that further publications may likely change their recommendations. And finally, very low quality evidence implies that any estimate of effect is very uncertain. So now that we understand the components of the kids list, we can talk about it in its totality. The findings of the kids list highlight the need for more evidence in order to further define and clarify ADRs in the pediatric population. However, it is important to keep in mind that the kids list should be used as a guide in conjunction with assessment of the entire clinical picture of the patient, as treatment with medications on this list may still be warranted depending on the clinical situation. The ultimate intent of the kids list is to improve medication safety in children, to educate clinicians and patients, and to serve as a quality control tool. So now that we have covered the basics of the kids list, we will talk about the specific medications included on the list itself. The first section we will be talking about today is topical formulations. Benzocaine is a topical agent typically used for mouth and gum irritation. However, the kids list recommends avoiding this product in children younger than 2 years of age for teething or pharyngitis due to the risk of methemoglobinemia. The active benzocaine ingredient is commonly found in products for teething such as Hurricane, Oragel, and Baby Oragel. It is associated with severe acute methemoglobinemia, which is characterized by abnormal levels of oxidized hemoglobin that cannot bind or transport oxygen. Eventually, if it goes untreated, it can result in cyanosis as well as seizures and arrhythmias. In order to combat this, methylene blue is administered intravenously to hasten the conversion of methemoglobin to hemoglobin. Eventually, in severe cases, patients may also need blood transfusion or oxygen therapy. In light of these ADRs, the FDA released recommendations regarding the risk of benzocaine use. So the FDA recommended a labeling change to include a warning about methemoglobinemia as well as contraindications for use. Additionally, the FDA recommended parents and caregivers to not use benzocaine for teething in children younger than 2 years of age. In terms of alternative treatments to benzocaine, they exist mainly of non-pharmacological supportive care. There is, however, one specific formulation of Baby Oragel that is marketed specifically to be benzocaine-free, and in this situation, this may serve as an alternative. Other non-pharmacologic alternatives include chilled teething rings and gentle gum massage. Our second product, viscous 2% lidocaine, is similar to the previous product that we spoke about. It is included on the kids list to be avoided in infants for teething due to its risk of seizures, arrhythmia, and death. Viscous 2% lidocaine is typically used for topical anesthesia of mucous membranes. There have been documented cases of overdose due to wrong dosing or accidental ingestion, as infants and young children may accidentally swallow too much when it's given to them for teething pain. As a result, the FDA now requires a black box warning as well as revisions to the warnings and dosage and administration sections of the labeling in order to describe the risk of these ADRs. And in terms of alternatives to viscous 2% lidocaine, again, strategies are mainly non-pharmacologic supportive care with use of chilled teething rings and gentle gum massage. Finally, our last topical formulation today is chlorhexidine, which is used as an antiseptic during procedures. In very low birth weight neonates, chlorhexidine has been found to cause chemical burns. In terms of specific data that has been isolated regarding the incidence of chemical burns with chlorhexidine in the pediatric population, there were actually 5 documented cases that occurred within the first 2 days of life in very low birth weight neonates. Recall that this refers to those neonates that are weighing in at less than 1,500 grams of body weight. In these specific cases, the incidence of burns was associated with the use of both aqueous and the alcohol-based chlorhexidine formulations. And for alternatives, other antiseptics that have been used include povidone iodine and alcohol. In our next section, we'll be talking about different antimicrobial agents included on the kids list and their risk of ADRs in the pediatric population. The first antimicrobial we will speak about is ceftriaxone, whose use has been cautioned in neonates due to the risk of kernicterus. So there has been documentation of bilirubin displacement in infants attributed to ceftriaxone use, which resulted in increased serum bilirubin and ultimately necessitated a change in antibiotics. Additionally, it was found that ceftriaxone has demonstrated significant competitive interaction with bilirubin albumin binding in vivo. So due to these findings, ceftriaxone is suggested to not be given in the neonatal population, as they are at risk of developing bilirubin encephalopathy. In terms of alternatives, ceftazidime offers similar coverage for enteric bacilli and is also a third-generation cephalosporin similar to ceftriaxone. Our second antimicrobial agent, chloramphenicol, is recommended to be avoided in the neonatal population unless serum concentration monitoring is used due to the risk of gray baby syndrome. When used in the neonatal population, chloramphenicol causes abdominal distension, hypotension, hypothermia, and an ashen gray discoloration, which is cumulatively referred to as gray baby syndrome. This syndrome occurs due to the developmental deficiency of glucuronoltransferase and inadequate renal excretion of unconjugated drugs in neonates. In terms of detecting gray baby syndrome, recently metabolic acidosis has been found to be an early sign of it, and it's associated with chloramphenicol use in the neonatal population. Finally, in terms of alternative medications, ceftazidime has been studied and was previously used in place of chloramphenicol in neonates. Our next class, sulfonamides, is included on the kids list to be avoided in neonates, also due to the risk of kernicterus. An exception to this rule is when sulfadiazine is used as adjunctive therapy with pyrimethamine in the treatment of congenital toxoplasmosis. According to a recent literature review, there is actually a clear lack of evidence showing the occurrence of kernicterus in neonates when sulfamethoxazole is administered orally for the treatment of pneumonia or sepsis. As a result, there is a need for further focused clinical studies in newborns, just in order to test sulfamethoxazole's ability to cause kernicterus and to address safety issues in the neonatal population. As we know, in terms of alternatives for antimicrobial therapy, this is dependent on the individual patient's needs, clinical scenario, and microbiology. Finally, our last class of antimicrobial agents is the tetracyclines, whose use is cautioned in children less than 8 years of age, especially in neonates for various ADR risks, including tooth discoloration, enamel hypoplasia, and retardation of skeletal development and bone growth in premature neonates. In terms of tetracycline use, this class has been known to complex and deposit inside growing bones. Therefore, tetracyclines must be prescribed cautiously throughout childhood up to 6 years of age if they're used, due to their effects on the bone and the teeth before they are fully calcified. However, the risk of tetracycline staining becomes diminished in girls at the age of 6 and boys at the age of 7, as all of their anterior teeth have formed. Additionally, as documented in previous studies, the risk of ADRs increases with greater frequency of exposure with the tetracyclines, as patients with 8 or more courses were observed to have noticeably darker teeth with tetracycline use. In terms of alternatives, again, this may depend on the patient's individual clinical scenario and should be decided on a case-by-case basis. For example, though, doxycycline carries the risk of tooth discoloration. However, it still may be used in the treatment of Lyme disease. And this is even in the case of the fluoroquinolones. So this class never even made it onto the kids list due to the class's benefit that was seen in urinary tract infections, cystic fibrosis, and community-acquired pneumonia. So this really highlights that certain patients may need various medications from scenario to scenario. And even though the patient, the medication may still be on the kids list, the patient may need it for their treatment. So next we will be talking about the dopamine antagonists first as a class and then as individual medications. The dopamine antagonists are typically used for nausea and vomiting. However, this class should be avoided in those less than 6 years old due to the risk of acute dystonia and increased risk of respiratory depression, extravasation, and death. So now, speaking more specifically about the dopamine antagonists themselves, we'll start with prochlorperazine. Prochlorperazine itself has been associated with sedation and extrapyramidal symptoms, which are disorders of the system that regulates posture and muscle tone. In addition to these, life-threatening persistent ADRs, as well as dystonia, dyskinesia, and Parkinsonism episodes have been reported. Extrapyramidal symptoms encompass the symptoms seen also in dystonia, dyskinesia, and Parkinsonism, as these are all characterized by involuntary movements and muscle contractions, as well as tremors. For metoclopramide specifically, there exist case reports of drug-induced tardive dyskinesia after both oral and intravenous administration of metoclopramide. So here we recall again that dyskinesia refers to involuntary movements. Furthermore, in preterm infants, there is a higher incidence of ADRs with metoclopramide due to excessive serum concentration as a result of prolonged plasma clearance. So now we can summarize the dopamine antagonists as a whole. Recall that this class may be used for nausea and vomiting. However, its use in those less than 6 years of age is not encouraged due to the extrapyramidal symptoms that we spoke about, and they may mimic serious diseases. Additionally, if antiemetics are prescribed, physicians should be aware of and emphasize possible side effects with the class so that if they need to initiate treatment, they can as so needed. Finally, in terms of alternative agents for the management of nausea and vomiting in the pediatric population, ondansetron and dexamethasone may also be used. All right, so our next class of medications on the kids list are the gastrointestinal agents, and I only have one for you guys today. Loperamide is an antidiarrheal medication that is recommended to be avoided in infants for acute infectious diarrhea due to the incidence of ileus and lethargy. When speaking about the risk of ADRs associated with loperamide, typically risks outweigh benefits in those who are younger than 3 years old, malnourished, moderately or severely dehydrated, systemically ill, or who have bloody diarrhea. However, though, loperamide may be used as an adjunct to oral rehydration and early refeeding in children who are older than 3 years of age with minimal or no dehydration. This is due to data that was isolated from a meta-analysis of 927 children, which showed that serious adverse events, including ileus, lethargy, or death, were reported in 8 children who were all younger than 3 years of age. Additionally, in this meta-analysis, serious adverse events were not reported in any children allocated to the placebo group. Our next class we will look at is the sedative agents. And again, I only have one for this class, but propofol is a medication that is indicated for use in general anesthesia. On the kids list, it is recommended to avoid doses greater than 4 milligrams per kilogram per hour for greater than 48 hours due to the risk of propofol-related infusion syndrome, or PRIS. PRIS is typically characterized by acute refractory bradycardia leading to asystole in the presence of one or more of the following parameters, which include metabolic acidosis, rhabdomyolysis, hyperlipidemia, and enlarged or fatty liver. Ultimately, PRIS can be lethal, and because of this, practitioners must exercise caution when using propofol longer than 48 hours at doses greater than 4 milligrams per kilogram per hour, particularly in patients with acute neurological or inflammatory illnesses. Currently, propofol is indicated for ages as young as 2 months old for maintenance sedation and 3 years old for induction, and this plays into our next piece, which is predisposing factors. So the predisposing factors for PRIS include young age, which we spoke about, severe critical illness of the central nervous system or respiratory origin, exogenous catecholamine or glucocorticoid administration, inadequate carbohydrate intake, and subclinical mitochondrial disease. In terms of PRIS treatment, if it does occur, patients may require hemodialysis or hemoperfusion with cardiorespiratory support. And in terms of our alternative agents, these include ketamine, dexmedetomidine or Precedex, and etomidate. Analgesic agents are another common class included on the kids list, and we'll investigate this class next. Our first agent in the analgesic class is codeine, which has been recommended to be avoided in children less than 12 years of age or less than 18 years of age following tonsillectomy and adenoidectomy due to the risk of respiratory depression and death. And these parameters are actually now black box warnings for codeine. So codeine is a prodrug that is metabolized by the liver by CYP2D6 enzymes to morphine, which is ultimately what is responsible for codeine's analgesic effects. However, due to patient-specific CYP2D6 activity, unanticipated respiratory depression and death have occurred in children receiving codeine who have been ultra-rapid metabolizers. So by this, we mean that these patients were able to rapidly metabolize the codeine into morphine, leading to the accumulation of morphine and an enhanced analgesic effect. Additionally, patients with obstructive sleep apnea may be at higher risk due to opioid sensitivity, coupled also with the potential of being an ultra-rapid metabolizer. Ultimately, a black box warning and contraindication was placed regarding use in children, especially in those who have undergone tonsillectomy and adenoidectomy. Alternatives for codeine use consist of non-opioid analgesics, including acetaminophen, ibuprofen, and naproxen. Next, we have the salicylates, which are to be used in caution with children with suspicion of viral illness, which we'll dig deeper into on the next slide. So Reye syndrome is a rare acute life-threatening condition characterized by vomiting and lethargy that may progress to delirium and coma. And in the clinical setting, aspirin has been known to increase the risk of Reye syndrome, especially in children who are recovering from viral infections, most notably influenza and the chickenpox. And this is due to the potential routine use of aspirin in this clinical situation. However, although salicylates are included on the kids list, it's important to remember that aspirin may still be required for therapy in the pediatric population, and this can be in certain situations such as Kawasaki's disease, post-ischemic stroke, and cardiac surgery. From clinical trials, aspirin use has been identified in anywhere from 3 years of age up to 18 years of age, depending on the scenario. In terms of our alternatives, we turn to our non-opioid medications, such as acetaminophen or ibuprofen, as they have not been associated with Reye syndrome in the pediatric population. All right, so another section of agents that we'll speak of today are the agents used to manage serum electrolytes. And again, I only have one for this section. So sodium polystyrene sulfonate, or Kayexalate, is recommended to be avoided in the very low birth weight neonatal population, less than 1,500 grams, due to the risk of colonic perforation. So Kayexalate is indicated for the treatment of hyperkalemia. In a case report of a 24-week-old hyperkalemic newborn weighing 650 grams, both cecal impaction and perforation were observed after treatment with Kayexalate enemas. Additionally, pathologic examinations showed Kayexalate crystals contained in the newborn cecal abscess. Furthermore, recent literature reviews demonstrated that the use of Kayexalate for hyperkalemia in this age group specifically may actually likely not be helpful for decreasing serum potassium and instead may be detrimental to infants. So because of this evidence and because Kayexalate may be detrimental in infants due to potential hemorrhagic colitis, transmural necrosis, and necrotizing enterocolitis, it was included on the kids list. So now getting back to the original issue of hyperkalemia, some alternative agents that can be used instead of Kayexalate include albuterol, insulin, and sodium bicarbonate. And finally, our last class of kids list medications that we will speak about are the neurological agents. So valproic acid is a medication used for the management of seizure disorders. However, on the kids list, it's recommended to be avoided in infants and must cautiously be used in anyone less than 6 years of age due to the risk of pancreatitis and fetal hepatotoxicity. So the main issue with valproic acid is that hepatotoxicity remains a considerable problem, especially in children younger than the age of 6. Polytherapy seems to be a common risk factor for ADRs, including hepatotoxicity and pancreatitis. However, other more serious ADRs, such as encephalopathy, seizures, respiratory disorders, and coagulopathy have also been frequently reported. When we use valproic acid, hepatic function should be carefully monitored, although current experience suggests that dose reduction alone may be effective in preventing these hepatic side effects. So finally, in terms of alternatives to the use of valproic acid, this is very patient specific as patients may be in different stages in the management of their anti-epileptic regimens. However, there are many anticonvulsants out there that they may use as alternatives. So now that we have gone over notable medications on the kids list, we will now review what we know with a case question. JC is a 14-year-old male admitted to the pediatric intensive care unit for observation following a tonsillectomy and adenoidectomy. For pain control following surgery, the physician prescribes acetaminophen with codeine. Which of the following describes JC's contraindications to codeine? All right, so yes, the correct answer here is D, age less than 18 years of age, as well as a surgical history of both tonsillectomy and adenoidectomy are both contraindications to codeine use. However, male sex itself is not a contraindication to codeine use. I also wanted to highlight that in this patient case, the patient's pharmacogenomics are unknown. So it's best to avoid codeine in this patient as JC may be an ultra rapid metabolizer of CYP2D6. And at this point, we're unsure. So now that we've covered medications included on the kids list, we can dive into the next section, which is notable excipients. This feature differs from the Beers criteria, which we may be more familiar with, and it's unique to the kids list as there are various excipients that may carry the risk of ADRs in the pediatric population. So first off, what exactly is an excipient? An excipient is a pharmacologically inert or inactive substance that serves as the vehicle or medium for a medication or other active substance. Essentially, an excipient may serve purposes in a medication such as a vehicle, a preservative, etc. Our first excipient class includes benzyl alcohol, sodium benzoate, and benzoic acid. This class carries the risk of gasping syndrome, which is a life-threatening condition characterized by multi-system failure and death in neonates following the administration of benzyl alcohol. So in order to avoid this, the kids list recommends the avoidance of doses greater than 99 milligrams per kilogram per day in the neonatal population. Benzyl alcohol, sodium benzoate, and benzoic acid are commonly found in products such as liquid Benadryl and some formulations of chewable montelukast and orally disintegrating olanzapine. A study including 10 premature infants in the neonatal intensive care unit demonstrated deterioration of multiple organ systems and eventual death with the use of benzyl alcohol. Additionally, the study investigators concluded that intravascular infusion of flush solutions containing 0.9% benzyl alcohol caused severe metabolic acidosis, encephalopathy, respiratory depression with gasping, and other abnormalities leading to the death of 16 infants. Blood and urine samples of the affected infants showed high levels of benzyl alcohol metabolites, including benzoic acid and hippuric acids. Eventually, after solutions with benzyl alcohol preservative were banned in their nurseries, investigators stated that there were no more additional cases of gasping syndrome or death that occurred. So our next excipient class includes ethanol and ethyl alcohol, which are associated with the risk of hypoglycemia and CNS depression, which can be enhanced if the patient is taking other sedating medications or CNS depressants. Because of these risks, the kids list recommends caution with use in those less than 6 years of age. Additionally, the kids list recommends a maximum of 5% ethanol with supervision. Ethanol and ethyl alcohol can be found in some formulations of amoxicillin, omeprazole, and duloxetine. Despite recent efforts by pharmaceutical companies to replace alcohol or reduce its content, there still remains on the market an excessive number of liquid medications such as teething preparations, decongestants, and cough medications containing alcohol in concentrations ranging from anywhere from 0.3% to 68%. Additionally, it is important to keep in mind that disulfiram reactions may be induced by alcohol-containing medications, especially when given with metronidazole, sulfonamides, and chloramphenicol. And when we speak about these disulfiram reactions, we may see symptoms including flushing, tachycardia, nausea, vomiting, arrhythmias, and respiratory depression. So finally, in addition to the risk of disulfiram reactions, acute ethanol administration may alter drug absorption or impair the degradation of other drugs, including altered clearance of phenobarbital, phenytoin, and warfarin. Our next excipient is isopropyl alcohol, which has been observed to cause chemical burns in very low birth weight neonates. So again, we recall that this means a neonate with less than 1,500 grams of body weight. Like ethanol and ethyl alcohol, isopropyl alcohol can be found in some formulations of amoxicillin, omeprazole, and duloxetine. In a recent case report, there were observations of second-degree and third-degree burns in 2 cases of premature infants with this very low birth weight, less than 1,500 grams. In these cases, isopropyl alcohol had either been used for conduction on electrocardiogram or preparation of the umbilical stump for arterial catheterization. Finally, in one case of a 756-gram male, the infant required vigorous resuscitation followed by clinical deterioration, including increasing hypotension, ventilator dependency, and intraventricular hemorrhage. And this is all due to isopropyl alcohol use. Next, we will talk about the class of excipients known as the parabens, which are used as preservatives. The parabens, which include both methyl and propylparaben, are recommended by the kids list to be used cautiously in those less than 2 months of age due to the risk of kernicterus. The parabens may commonly be found in products including acetaminophen, benzonatate, and diphenhydramine. In a study assessing the effect of paraben preservatives on albumin binding of bilirubin, the displacing effects of methylparaben were found to be additive. Additionally, methylparaben alone was found to be a weak competitor with bilirubin for primary albumin binding sites, but a strong competitor at secondary sites. Furthermore, propylparaben was observed to bind to albumin, but it itself does not cause bilirubin displacement. So in conclusion, medications and injectable saline or water preparations containing methylparaben should be avoided in jaundiced newborn infants when high affinity albumin binding sites approach saturation. And finally, our last excipient is propylene glycol, which can carry the risk of lactic acidosis, CNS depression, hypoglycemia, hemolysis, and seizure. The kids list recommends avoidance of doses greater than 3 grams per day in neonates and cautions against doses greater than 34 milligrams per kilogram per day in neonates. Propylene glycol can be found in various formulations of acetaminophen, amoxicillin, and clindamycin. In general, the accumulation of this excipient potentially results in hyperosmolality, lactic acidosis, and renal and hepatic toxicity. In a prospective assessment of propylene glycol tolerance in neonates, large doses of propylene glycol were administered during a session of IV nutrition, and serum hyperosmolality was reported in small premature infants. During the IV nutrition session itself, the major source of propylene glycol was actually found to be an IV multivitamin solution. However, in this assessment, it was observed that unintended propylene glycol administration at no more than 34 milligrams per kilogram per day for a maximum of 48 hours seemed to be tolerated in preterm neonates and did not affect short-term postnatal adaptation. So this is where that kids list recommendation comes from. Finally, further studies regarding propylene glycol's disposition, safe levels of exposure, and long-term safety data in neonates are needed in order to make more appropriate recommendations in the future. So now that we've completed our section on excipients, let's review with another practice question. Which of the following products is known to contain propylene glycol in some of its formulations? Yes, so as we've seen from reviewing this section, we know that propylene glycol is found in various formulations of acetaminophen, amoxicillin, and clindamycin, so the correct answer here is A. So now that we've reviewed a bulk of the kids list, I just wanted to summarize some key points about the kids list to keep in mind when practicing. Firstly, to start off, we recall that the purpose of the kids list is as a guidance tool used to improve medication safety in the pediatric population. This guidance tool, in contrast to the Beers criteria, also includes excipients in addition to the medications that may potentially pose the risk of ADRs in children. Finally, I want to emphasize again that the kids list is not meant to be used as a strict guide for absolute contraindications, but rather as a starting point for clinical decision making that can be used by interprofessional teams. Remember that in certain clinical scenarios, medications included on this list may still be used if benefit outweighs the risk in certain patient cases. And finally, as time goes on and with additional research and clinical experience, the kids list will be able to expand and its recommendations will evolve over time. So that about concludes my presentation. I want to thank you all for attending, and I will also now open to any questions that you may have. Okay, so if there are no questions from the chat, the way that this is going to work is I will email everyone who attended with the post-assessment questions, and then you will all just have to send me the answers back in another email. And once I receive your answers, I'll be able to give you the CE code for today. Thank you so much for attending.